Good afternoon, everyone, and welcome to Grand Rounds. My name's Tom Ford, and I'm the chair and organizer of Grand Rounds. And I was just saying to Fiona, who's today's speaker, that sometimes we go a long time without hearing from a certain department, and then, like buses, they come along in threes. But we had a talk from our colleagues in CAMHS a couple of weeks ago, speaking about suicide prevention in children and young adults. And this, I think, ties in very nicely as a sort of suite of talks, because Fiona's angle here is going to be slightly different, talking about the gender differences in suicide and more into adulthood. Fiona contacted me last year to ask for a talk, and there's been a little bit of struggling around with times. So, but I'm delighted that she's here now. She's a clinical psychologist working in the CAMHS department, but also has an active research role. So again, I just put out that I think we call this the trigger warning. I think she's going to talk about suicide. It's an important topic, but many of us in our lives have been touched by suicide and attempted suicide. So just bear that in mind. But it's, I think, really, really important that we talk about this and hear from experts. And we have one here today. So Fiona, thank you very much for joining us. And I'm really looking forward to your talk.
Thank you. Thanks for that introduction. So as Tom has just said, I'm Fiona. I'm a clinical psychologist and I work in the Perth Child and Adolescent Mental Health team for 50% of my time. And for the other 50%, I'm lucky enough to have a role where I'm helping to support and coordinate psychological research across Tayside. And I'm a fairly new clinical psychologist. I qualified in 2021. And before that, I had a past life as a researcher. I worked in Dundee, actually, at the University of Dundee and at Abertay. So it's nice to be back in Tayside. So I'm going to talk about, I guess, some of the work that I was doing back in my past life with some kind of local examples of research that's local to Tayside, but then talk about this bigger issue of why do men die by suicide? And I've pretty much stolen this slide, or the information on this slide, wholesale from the talk 2 weeks ago, where I think that Jane, Fiona and Sharon did a really great job of talking about the work that's going on in Tayside to support young people who are feeling suicidal. And if you haven't had a chance to catch up with that talk yet on YouTube, I would recommend it. It was a really, especially for me working in CAMHS, it was a really interesting talk, but applies more generally, I think. So just being aware that, as Tom said, this is a really difficult topic to talk about. Everybody's been touched by suicide in some way or other. So it's really important for us all to be aware of that, and that thinking about these things never gets easier. You know, even working day by day with young people who are feeling suicidal and immersing myself in the research, it doesn't get easier to think about. So these resources are always really helpful to have around if you want to, if you're working with somebody, or is there somebody in your personal life that you think needs a bit of support. Samaritans have their phone line and an email option as well. And NHS 24's breathing space is another really good option for someone to talk to. And then we've got our local Tayside app, which Suicide Help, which is really useful if you're working with someone, or you know someone that's feeling suicidal. It's got it signposts to lots of resources, and has a nice kind of safety planning option. So that's really helpful as well. So just to be aware that this is difficult, but it's important, and we're tackling some of the more difficult aspects of working, I guess, working with men who are suicidal, identifying who those men are, knowing how to support them, but also just in not working with, just in our lives as well, just sit with amongst the people that we know. So I wanted to start with just a bit of an exercise, and this isn't a test. It's not, there aren't right or wrong answers. There's not, it's just, I guess we'll revisit these two case examples later on in the talk. And I really just wanted to do this as a way of thinking about how my thinking has changed in terms of the way I've thought about suicide risk and the way I've thought about supporting men and women over time. So you can give me answers to this in the chat, or turn your microphone on and speak out loud if you want to, but also it's great if you just want to think it through. So there's two case examples here. They're invented. I've just made them up, but so it's two patients that have presented to their GP, and I want you to think about which, or both, or either of them, you would want to refer on to more specialist mental health care, so community mental health team or similar, and why you would want to do that. And would you consider one of them to be at a higher risk of having suicidal thoughts? And if so, why? And just to keep them kind of the same as possible, they're both 44 years old. They're both from the same postcode area, so they live in a very similar kind of area of socioeconomic status, and they're both single. So patient A presents to his GP with substance misuse, that's alcohol and cocaine, and with risky behaviour, so unprotected sex. He's been asked to make an appointment with his GP by his employer's occupational health service, who are concerned about him working beyond the contracted hours and becoming burnt out. And then patient B presents with tearfulness and fatigue and describes feeling hopeless and worthless. And they've chosen to attend their GP because they're finding it difficult to cope with those symptoms and would like support to feel better. So if you just want to think about those two questions, which, if either of them, would you want to refer on for more specialist support, and which of them might you consider to be at more risk of having suicidal thoughts? And it'd be great if anyone wants to share their thinking, but otherwise just think about it. Okay, so Sinead has said you'd need more information, but on the face of it, patient A is at higher risk. I'd be interested to know what your thoughts are about the greater risk for patient A, if you can give any more detail, or if anyone else has any different thoughts or feels the same way.
Do you want me just to jump in, Fiona?
Yeah, thank you.
So I think patient B would probably need a bit more information about the presentation, but patient A has quite a few kind of high risk flags for me: the substance use associated with impulsivity, the risk taking, which may reflect underlying issues, and again, impulsivity and acting on suicidal thoughts in an impulsive way. But also they're in employment, so that's a kind of potentially protective factor. B maybe suffering from quite a severe depressive episode, but we don't know all the kind of potential depressive symptoms. So I would refer them both. I think they're both quite risky. Yeah,
thank you. And Martin said that the risky behaviour is a bit of a flag, but also so is the hopelessness of patient B. So I think probably everyone would agree that the first thing you would need to do is get a lot more information. But as you'll know, if you take referrals from kind of primary care referrers, there's quite often not a huge amount of information because it's not possible either to get the information, just there not being the time in the appointment to get that, or maybe the patient isn't willing to share that much information. So although these are very brief examples, they're not that unusual sometimes for the amount of information that a community mental health team or similar might be getting. So if we just keep that in mind and the kind of thoughts that you've maybe had about them both, and we'll come back to it a little bit later on. So I want to start by talking about the gender paradox of suicide, which is basically that far more men worldwide die by suicide than women do. That's despite women reporting more suicidal ideation and reporting more and making more suicide attempts. I want to talk about some of the kind of theoretical possible explanations for this, and then talk about how difficult it is to actually predict risk with real life people that aren't kind of case examples. And then talk a little bit about some of the psychological predictors of risk, and one of those which is potentially most related to the reasons why men may die by suicide is masculinity, and what we know about that and really what we don't know about that. And overwhelmingly, the conclusion of all of this is that it's all inconclusive. We really don't know, but there's a lot to learn. But I think by having these conversations, thinking about the complexity that we're dealing with in these issues, that puts us all in a stronger position to be aware with the people we're working with and the people that we're interacting with. And it also kind of directs us towards potentially useful future research directions. So these are the statistics that are taken. These are taken from the Samaritans website every year when each of the UK countries releases their deaths by suicide statistics. The Samaritans do a really lovely job of kind of making these sorts of diagrams that make them really easy to see, and they're usually quite visually striking and shocking. So this is for the UK. In fact, this is for Scotland. So the figure on the left these were deaths by suicide in Scotland in 2021. And you can see, I think there were 753 deaths by suicide that year. And of those, 75% were men. So it's a big difference. It's a really big difference. The graph on the right shows this isn't a pattern that's unique to 2021. This is the purple line is men and the blue line is women. And the orange line is the combination of the two. So this is a pattern that's extended over time. It's not new, and it's worldwide. So I believe this year that there is no country in the world where the rate of suicides is higher for women than men. It's universal. The size of that difference varies. So there's some countries in Asia where it's something like 1.2 men per woman that die by suicide. But then there are countries in Eastern Europe where it's 6 or 7 times as many men as women dying by suicide. So it's a big difference. And something to bear in mind in Scotland is that we do have the highest suicide rate in the UK. It's difficult to compare because the way that we investigate deaths and the way we code deaths differs across the countries of the UK. But even so, I think the difference is big enough that we can be fairly sure that we do have a higher suicide rate than our kind of nearest neighbours. So it's something that obviously the government has prioritised. It has its new action plan. Scotland is very active in suicide research. There's several kind of really big research groups leading our understanding of suicide risk and prevention internationally. Yet still we're stuck with this kind of question of why are more men dying by suicide than women? And if we know the answer to that, does that make us any better at supporting men who are feeling suicidal? So one possible explanation, or as I'm sure we're all aware, there will be very many explanations that all interact with each other in a kind of such a complex behavior as this. But the one that I first started thinking about was the roles that traditionally we've allocated men and women to. And I should say at this point that the vast majority of the research to date has looked at a very traditional born as female versus born as male. There's a growing body of research that's still very small, but it's growing rapidly, looking at gender and sex in a broader way than that. So looking at non-binary presentations and how that relates to suicidality, but still to date, the vast majority of research has used our traditional sex at birth to look at the group of men versus the group of women. So that's what I'm mostly talking about today. And traditionally and historically, pretty much since we were hunter-gatherers, we've tended to allocate, as societies, we've tended to allocate men and women to distinct roles, not always and to different degrees, but more or less over time, we've tended to, and particularly in recent kind of history, men being the breadwinner, so being responsible for bringing in the resources needed to raise a family, so money, more recently, and women to a homemaker role of being more likely to be staying at home, taking care of the home and children, and being responsible for the social aspects of family life. Obviously, that's changing, and we're adjusting to that. But historically, that has typically been the pattern, particularly since we had nuclear families. So that makes us wonder, are there particular stresses associated with fulfilling those two different roles, which kind of predispose us? You know, maybe are there stresses associated with being the breadwinner which make you more likely to feel suicidal and to act on those feelings compared to the different stresses associated with being a homemaker? Also, we know that access to means, so the means to take your own life, and I won't talk about specific kind of methods of suicide because there's no need to, but there's evidence that certain professions or certain activities give you easier access to lethal means of suicide, and maybe on average, in general, people who are fulfilling the breadwinner role have had easier access to those means. So Dundee is a really interesting place to kind of try and test out that hypothesis, because in the 19th to early 20th centuries, there was a bit of a kind of gender role shift in that the major industry was the jute mills, and women were the majority of the workforce. And that's just because women are smaller and we could fit in between the machinery, and the children were employed for the same reasons, and also women were cheaper to employ. But it did mean that in at least the working classes, women were the main breadwinners for the families, and men stayed at home, and they were known kind of locally as kettle boilers because they were staying at home, looking after the home, boiling the kettle, looking after the children. And at the time, Dundee was known as She-Town for that reason. So given that it's a time where gender roles kind of, or gendered social roles swapped, I was interested to know, did anything change in terms of suicidality? If we're thinking that it's maybe the gender roles that are predisposing us to different kind of expression of suicidality, did that change when gender roles changed? So I worked with a group of undergraduate and master's students, and who looked through the newspaper archives from 1844 to 1950 to score and record data on every report of a suicide attempt or a death by suicide. It wasn't a fun project, but it was a really interesting insight to the time in Dundee. And what we had kind of expected, and we weren't expecting a nice clear-cut shift at all, because obviously this is much more complicated than that, but we wondered, would the female suicide rate increase and the male suicide rate decrease? And there was nothing as straightforward as that. So actually reports of suicide attempts by men did drop, which sort of supported our hypothesis, but so did deaths by suicide by women, which didn't really support our hypothesis. And actually looking at, there haven't been that many studies that have kind of looked at the same idea, but those that have, for example, a group in Canada looked at the movement of women into the labour market in the 70s and 80s and how that correlated with rates of deaths by suicide by men and women. And what they found was that it was so complicated by kind of local attitudes towards women working and local attitudes towards men staying at home, as well as the kind of income level of the family and how much stress the family incurred as a result of that gender shift. So that's all to say, it's not as straightforward as saying men and women inhabit different roles. Therefore, we experience distress and express suicidality differently. So what there is a huge body of literature over the last 100 years looking at risk factors for suicide. And this literature has mostly developed through comparing what was going on in the lives of, or what were the kind of traits and characteristics of people who died by suicide compared to people who died by other causes, or who took reports about the lives and characteristics of people who'd made suicide attempts or experienced suicidal thoughts, and compared them against people who hadn't experienced suicidality, to kind of identify the factors that distinguished those groups. And there's an enormous list of risk factors. We're really, really good at knowing at a group level which groups of people tend to have higher suicide rates. So some of the big ones that we tend to see all the time would be sex. So as we've already said, around the world, the group of people that we call men have a higher suicide rate than the group of women, the group of people we call women. Age consistently is a risk factor, although it changes and varies. So at the moment, the kind of age group with the highest suicide rate in Scotland is 45 to 54 for men and women. We know that the socioeconomic status correlates with suicidality, where you live in the world and where you live kind of in terms of being rural or urban. Having a psychiatric diagnosis or a physical health diagnosis, your life events and stresses and trauma that you've experienced in your life, belonging to a minority group, and having access to means. These are all kind of factors which tend to show up as being more common in a group of people, for example, who've died by suicide. There hasn't been a lot of work so far to look at whether those risk factors differ for men and women. There was a really nice systematic literature review recently by Cara Richardson, who's a PhD student at Rory O'Connor's lab at the University of Glasgow. And she looked at all the literature so far, which has specifically looked at risk factors for men. And they weren't particularly, I don't think, particularly different to the ones that we tend to see for just people in general. So alcohol and substance misuse was one of the strongest risk factors for men. Being single, having a psychiatric illness, various socio-demographic factors, having a physical illness, and having experienced negative life events or trauma. So again, these tend to show up in different studies as being important risk factors for people in general, but they seem to be the strongest for men. So given that we know a lot about which groups of people on the basis of psychiatric diagnosis or socioeconomic status or experience of negative life events, we know which of those groups is likely to have the highest suicide rates. Can we not then just apply that to individual people? Can we not then just look at someone who's presenting to us in clinic, or a friend who's coming to us and they don't quite seem right? Can we look at that list of things and think, well, they're male, they're this age, they're single, they're misusing alcohol, therefore I'm really concerned, I'm going to refer them on for specialist support. And the problem is that that doesn't work. In fact, it's worse than chance. So when we try and assess risk, and this is based on kind of clinical risk assessment research, risk assessment based on those population level risk factors is poor. And in fact, in lots of cases, it's worse than chance at predicting who's actually at risk of suicidality, of suicidal behavior, which makes our jobs really, really difficult. But there are lots of good reasons why it's the case. So we know that it's the same problem as anyone who's working with psychological interventions or medical treatments. We know what the evidence base tells us. They tell us that in a group of selected controlled participants who are all the same age and don't have any comorbidities, this therapy works really well. But when you're in clinic with real people with complex presentations and comorbidities and all sorts of individual differences, it's very difficult to judge whether this kind of indicated intervention is going to work for that individual person. People aren't average. It's also really difficult to take population level stats and apply them to individuals, because given, of course, that every suicide has an enormous cost to communities and to the people around the person who's died, statistically, it's considered to be a rare event, which makes it more difficult to predict. And we also don't know the meaning of those risk factors to the individual. So, for example, a relationship breakup is a predictor of risk. People who've just been through a breakup are a population of people who have a higher suicide rate than people in a happy relationship. But that could happen to me. My relationship could break up, and I could be devastated and feel really alone and hopeless, and that could increase my suicidal thoughts and my risk of taking action on those thoughts. But for someone else, it could be wonderful. They've been wanting to get out of this relationship forever. They couldn't work out how to end this relationship, and finally they're free and they're financially better off and everything's wonderful, and it enhances their well-being. So I think it's something that's been missing in the kind of methodology of suicide risk assessment and management, is the psychological meaning of risk factors and the psychological traits and processes that lead from those risk factors to the development of suicidality. So that might be looking at someone's personality traits, looking at what's important to them and their values, and understanding how all these risk factors interact in the context of an individual complex person. So this was kind of a shift in thinking for me, of going from being a sort of researcher looking at almost the ecology of suicide. I was always looking at predicting how suicide rates changed over time in Scotland and how they differed across different health boards and what was predicting that, to finding, as I retrained as a clinical psychologist, that wasn't at all helpful for me working with individual real people and the complexity of their lives. So beginning to think about the kind of psychological factors which might be more important to understand when working with real people. And thinking particularly about men and psychology and what it means to be a man and masculinity. I was lucky to work with a PhD student, Charlotte Starkey, who was awarded her PhD this week. So she's Dr. Starkey now. And she was really interested in psychological masculinity and whether that contributed in any way or predicted suicidality. And what we found right back at the start of her PhD was that, so we've all probably, when I put up this slide and it said masculinity, we probably all have kind of an instinctive understanding that this is something like being macho and strong and probably emotionally restricted, or all of the sorts of stereotypes that we have around masculinity. And to be fair, probably your instinctive understanding is probably about the same as the state of the current literature looking at masculinity, because there is no consensus on what it is. So looking at the literature to try and work out, okay, we want to look at masculinity and see if that predicts whether men are more or less likely to feel suicidal. And okay, we need to know what masculinity is, and there's no answer to that. So these are just some of the traits that it's defined as or operationalized as in the literature. So from things like being stoic and independent, confident, assertive, angry, proud, aggressive, restricted emotionality, proud. But this is just a tiny fraction of the ways that it's operationalized, which is quite a common problem in kind of psychological research, is that there's never a consensus on a psychological trait really about how we should define it and measure it. But it does make our lives more difficult if we want to know how that kind of construct affects something as complex as the development of suicidality. And it's important to say as well that even though there's not a lot of consensus on what masculinity is, there is consensus that it's not something that men have and women don't. Men in general tend to score more highly on measures of these kinds of traits than women do, but we're all more or less masculine, regardless of the gender that we were born as. And I think in the last maybe decade, our understanding of masculinity and what it means to be male and female has massively changed. So the kinds of measures of masculinity that exist in the literature are very out of date. So it's important to explain that caveat before I show you the results on the next slide. So the first thing that Charlotte did was to review the literature and find all the studies which had used kind of good, validated measures of something about masculinity, whatever version of masculinity they chose to use, and a good, valid measure of some aspect of suicidality, either having had suicidal ideation, having reported making a suicide attempt, or some studies compared groups of people who died by suicide with groups of people who died by other causes. And we identified, so don't worry too much about this figure, it's more just to guide me to explain the results to you than anything else, but we identified 14 studies, which are listed down on the left here. So these are the 14 studies that had validated measures of masculinity and suicidality. And the kind of blob that's associated with each one is the kind of strength of the relationship between the two. So how strongly masculinity and suicidality were related to each other. And this line in the middle is the kind of zero line. It means there's no relationship between the two. So regardless of your level of masculinity, that had nothing to do with your experience of suicidality. And I should also say these studies, many of them also contained women. So we looked at whether the patterns that I'm about to describe were different for men and women, and they weren't. So masculinity has similar effects on suicidality, regardless of whether you're male or female. If the blob is on this side of the graph, on the right side, it means it's a positive relationship, which means the higher you scored on that measure of masculinity, the more likely you are to have either thought about or attempted suicide or to have died by suicide. So on this side, it's all the results which show, yep, the more masculine you are, the more you are at risk of suicidality. And then there's one on this side, which is a negative relationship, which means the higher the masculinity, the lower the suicidality. And for this study, the measure of masculinity was agency, which is your kind of your ability to think of yourself as someone who can make changes in your own life and take charge of those changes. So perhaps not surprising that that's protective against feeling suicidal. You feel like you can solve your problems, or that you can take responsibility for your own life. So but in general, when we looked across the results of all these studies, in general, there was a small relationship between masculinity and suicidality. In general, the more masculine, the more likely you are to have had suicidal thoughts and or acted on those thoughts. However, it's small, and all of the studies use different measures of masculinity. So it was really difficult to say, is it a particular type of masculinity? For example, this one up here, which is one of the strongest relationships, was it this kind of masculinity that they measured here, which was really important in increasing risk of suicidality? And no, not really, because it didn't bear out in other studies. So very, very messy. The other thing I want to point out is, and again, don't worry too much about the details of this graph, but because there were 14 studies and they'd measured suicidality in different ways across the studies, it was possible to group them into those that looked at suicidal ideation. So whether someone had thought about suicide or not, compared to those who'd moved on from that and taken action on those thoughts. And basically what this graph is showing is that there were many more studies that looked at suicidal ideation compared to suicidal action, but that the effect of masculinity was stronger in those studies that looked at suicidal action. So it might be, and I wouldn't want to conclude anything on this because it's such a small sample size, but it's possible that if masculinity does play a role, it's in the stage of moving from having thoughts of suicide through to actually taking action on those thoughts. So Charlotte was then wanted to look at kind of her own sample. She wanted to test whether kind of looking at the specifics of what traits of masculinity are correlating with suicidal ideation or suicidal action. And these results were from a sample of people who were just recruited through an online survey. But she's followed that up with a study looking at people who were in A&E in the 48 hours following a suicide attempt. And the results are, the patterns are more or less the same. I'm just not going to report the results of both studies just for the sake of time, and yeah, because they're very similar. So in this study, there were 195 participants, and they were asked to tell us whether or not they'd ever had thoughts of suicide and whether or not they'd ever attempted suicide, and then to rate themselves on a whole series of different kind of traits of masculinity, including those that I showed you on the previous slide, but lots of others as well. And the results are really complicated, and perhaps not surprisingly, given that the meta-analysis results were complex, and we've already said we don't really know what masculinity is. So some masculine traits, specifically being cynical and being hostile, did increase suicidality, but not directly. So cynicism and hostility were associated with higher anxiety and depression. And they were also associated with being more likely to use maladaptive coping strategies. So that's things like misusing substances or using risky behavior to cope with stress. And it was those things, it was anxiety, depression, and maladaptive coping that were associated with increased suicidality. So masculinity seems to work indirectly through its effect on other variables. And other masculine traits, so being egotistical, dictatorial, active, self-confident, standing up well under pressure and not giving up easily, they were actually associated with reduced suicidality. So those things seem to be protective against developing suicidal thoughts. And again, they worked indirectly. So they were associated with lower anxiety and depression, and also with more social support. And those three variables in turn were associated with lower suicidality. We expected that masculinity might be associated with help seeking. So there's a huge literature telling us that men don't seek help, or that men are much less likely to seek help for anything, but in particular for mental health difficulties. So we maybe expected masculinity to be related to being less likely to seek help, and then consequently that might affect suicidality, but we didn't find any relationships with help seeking. And there were no differences either between men and women. So again, the relationships between masculinity and everything else and suicidality were the same for men and women. So what we know so far is that we know that more men than women die by suicide. We don't yet have good evidence that there are particularly different risk factors for men compared to women. I don't know if that's because the research hasn't focused on that yet, or just that there aren't different risk factors at a group level for men versus women. We've got some evidence that masculinity, which you think might relate to a gender difference in suicide, that it's related to suicidality, but it's both a risk and a protective factor, and it seems to work through its effects on other things like mental health or coping strategies or social support. So again, nothing straightforward or particularly useful for us to use when we're working with people who we're worried about. And I think what's more interesting is what we don't know. So are we responding appropriately to people who present with symptoms that we don't already have in our mind as being linked to depression or suicide risk? So if we're thinking about, and our training is about, these are the risk factors for suicide, and we've got those in mind when we're working with someone, is that blinding us a little bit to noticing what's actually happening for that individual person? Likewise, if we work with DSM or ICD criteria for depression, If someone presents with symptoms that don't match those, so we don't think of them as being depressed, so we don't think of them as being at higher risk, is that getting in our way of understanding who needs help and who needs support and what kind of support is likely to be helpful? Are we doing enough to reduce stigma? So at the level of individuals, but also at a societal level. So, I mean, we're all aware of different campaigns that have happened in the media and kind of cultural shifts in encouraging people to talk when they're not okay. And around the world, there's been a lot of work kind of trying to normalize men experiencing mental health problems or feeling suicidal. Is that enough? Are we doing enough? And importantly, how can we integrate our understanding of the psychology of suicide, not just counting up risk factors, but thinking about their meaning to the individual and that person's kind of unique psychological processes and mechanisms into our assessment of risk and into our interventions? So I just wanted to kind of end on the following. So the way that my kind of thinking has been going more recently is this kind of model of, and it's called Male Depression. There's a research group in Canada who have done a lot of work at identifying a distinct clinical phenotype of a much more externalizing profile of symptoms that a group of men, and it's not as if all men present with this phenotype of depression and all women present with the internalizing version that we're more familiar with, but men are more likely than women when experiencing depression to exhibit symptoms like irritability, anger, substance misuse, risk-taking, impulsivity, and over-involvement with work. And men with this profile are more likely to have made a suicide attempt. So we know that this profile is more risky. We also know that up to 60% of men who die by suicide have accessed health services in the year up to their death. So there's an opportunity for us to be, I guess, approaching our evaluation of people's well-being, their level of distress and their level of risk with a more open mind that's not kind of clouded by what we think someone who's at risk should look like, and thinking about them as an individual and how risk is playing out in their lives. And I think it's also really important that we reflect on the influence of our own and not just our clients' gender socialization. So we're all raised to think that men and women act in different ways, think in different ways, do things differently, behave differently, which absolutely must cloud our judgment. And I think sometimes, you know, even as someone who spent a long time researching gender differences in various behaviors and who works clinically, and, you know, I'm a psychologist, I have to be very reflective. I still catch myself making assumptions about people on the basis of their gender and have to be really aware of that. So coming back to these two presentations and thinking about, you know, as somebody said right back at the start, probably the first thing you would need to do is get a lot more information. And that's, you know, in mental health services, we do have the luxury of that. We do a really thorough assessment. But I wonder whether we really think about the kind of the way that those risk factors in those individual patients are meaningful to them and how they interact with each other and what else is going on in their lives in order to base our judgment on something more than just ticking off risk factors that we know are important at a population level. So yeah, so that's pretty much the kind of conclusion of everything I've talked about, is that we don't know the answer to the question that I gave at the start. We don't know why men die by suicide. It will be that there are as many reasons as there are deaths by suicide. It's individual and it's complex, but in spite of that, can we be better? Can we be more reflective? Can we be more aware that people present differently and work towards a better understanding of how we impose our own stereotypes and our own beliefs and assumptions when we're working clinically with people? Thank you for listening.
Thanks very much, Fiona. There were some really, really interesting things in there, and I think you've done a very good job of talking us through these stereotypes and the assumptions that we make about people. And I do certainly appreciate that the evidence base takes a long time to catch up with things, and so this data is about men and women in that sense of sometimes it's gender at birth, sometimes it is are, how do you describe it? The male type roles and female type roles. So, but I think this is really very interesting. Are there any questions? There are questions that are coming up through the chat. Do people want to say them, or do we want me to read them out? I'm very happy for people to just stick their mics on.
I could
Julian,
answer. Sorry.
Yeah, so I'll just read out because on the recording people can't see the chat. So rather than relatively high masculinity, what about relatively less femininity? Might less feminine characteristics amongst men be a contributor to the risk in men?
Yes, would be my answer, possibly. I imagine it would be as messy as the masculine version. We do have data on femininity. We haven't analysed it yet. The problem is, again, it's as out of date as the measures of masculinity. And it feels like what we need to do is have a big kind of qualitative study of what is masculinity and femininity now in 2023. What does that mean to us? And what are the traits that we should be looking at? But yeah, I agree. Femininity is a separate dimension that I think is as interesting.
Kate says, sorry that she arrived late, so you may have already covered this, but is there any data on family status? Does being a parent act as a protective factor on suicidal action from women more than men, or men than women? Or is it is it changed with the tide as children get older and leave and etc.?
Yeah, I'm really glad you asked this. I find this really interesting, actually. So we know that being in a relationship is more protective for men than it is for women. And most of the literature shows that being a parent is protective, but it interacts with things like financial stress. But it's interesting, there's some cultural differences. So I was reading a study recently, and it was on Black American men and how important being a father was to their identity, and that was a very protective factor for them in terms of suicidality. But it in comparison to a different group, and I can't remember what the comparison group was, sorry, but it was a much more protective factor for that group of men. So there seems to be a cultural influence, but it is protective for both, but I guess it's kind of contextual as well.
Very interesting. I was reflecting on my own experiences of suicide within my family. My grandma took an overdose. She was in her mid-70s, I think, and this was nearly 20 years ago. And we talked about it as a family. She was lonely. Her children had moved away. Her grandchildren had moved away. Her family, her friends had either died or moved away, and she was just profoundly lonely. And she found her being a parent, being a grandparent, the thing that kept her going. And when that disappeared, that's what led her to take her overdose. But as you say, those are actually things I think that you've said that are recognized as contributing to suicide. But we could we have predicted that based on individuals? Very, very difficult. More questions have arrived. In the community study, were the traits scored on how the participants felt around the time of admission to hospital, or how they have perceived themselves generally in the past? E.g., I bet that people who would normally rate themselves higher in confidence, activity, agency, etc., rate themselves lower around the time of a suicide attempt. And how does this affect this data in the studies?
Yeah, it affects them massively. So Charlotte attempted to ask to kind of amend all the measures to be how have you felt in the last week, or was it the last fortnight? It was relatively recent anyway. But a huge kind of moderating factor in all of the studies like this is the length of time between say, for example, someone saying, yes, I have had a suicide attempt, and it might have been 10 years ago, but rating my masculinity is the way I feel today. So of course, those two things aren't going to be correlated. So I think that adds a huge amount of mess into the data. I think you're right.
Chris Burns says, nice talk, thanks.
Thank you.
That's to take to your appraisal, well done. Is there any data on a link between masculinity and identification with social groups, which might act together to impact upon likelihood of suicidal ideation or completion?
That's really interesting. I don't know, actually. I can imagine that being the case, but I don't know about data. But that's something that I'm going to look at now. Thank you.
Francis Travis has said, just piggybacking on Chris's question, how does perceived isolation link in?
Yeah, that's huge. So again, from Rory O'Connor's lab in Glasgow, there was a systematic literature review I think 2 years ago, I think I've included all of these in the reference list at the end, just if anyone's interested, about loneliness. So I guess that's not perceived isolation specifically, but sorry, that was quite a funny joke that she's just made, that she-town should have been done she, which is much better. Yeah, they missed a trick. Yes, I think loneliness and lack of connectedness to different social groups is a really important predictor of well-being overall, but also specifically to suicidality.
It's the complexity involved in this really strikes me, even with the questions and how there are no definitive answers to this. And you made an example earlier on as if your relationship broke up, that could be a good thing actually, and you could have been trapped in that. And the isolation, some people like being alone. Some people actually crave that, and some people prefer to be in groups all the time. And so trying to use that as predicting must be, well, it clearly is very challenging, very difficult. And yes, of course, she-town to done she would have been it is a mistrick, as you say. Richard Day, friend and colleague. Hello, Richard. Not seen you in a long time. You've made some references to the relative differences between male and female suicides in terms of method, men generally being more violent. But it is striking how in the postnatal period, women seem to characteristically use more violent methods, much less overdose and presumably more physical methods. I've never seen any vaguely satisfactory explanation for this. I suspect his question is, have you?
Yeah, no, and I didn't know that. That's really interesting. Yeah, I didn't know that, and so I certainly don't know if there's any kind of any explanation that makes any kind of sense. But again, that's something that's really interesting that I will now go and look into. I just wanted to say as well, coming back to the point that Tom, you made about, your experience in your family, which I'm really sorry that your family experienced that, and how many families or friends I've spoken to who have so much guilt about, should I have known, these are risk factors that show up, and should I have spotted them? And I think, I don't know about other people's experience, but my own experience has been, we are, as human beings, just we're really good at hiding this from the people around us, and B, most of the time we're shocked when we find out what's happened. These things don't seem to be obviously predictable to us, and I think there's so much guilt around about how we should have known or we should have noticed that we don't, because it's kept so secret and hidden. I don't think that those are unusual conversations that you were having, but I think it's important to flag that no, you shouldn't have, you couldn't have known. And yeah, sure, maybe we could all ask more questions and pry more, but sometimes the cues to even do that aren't there. So yeah, I think it's important to address that.
Yeah, Fhiona's got her hand up.
Yeah, I think one of the big confounders is the severity of the mental illness. So coming back to Richard's point about, people in the postnatal period being more likely to complete suicide and using violent methods. And I think that's really quite telling. The sickest people I've worked with probably are postnatal depression and psychosis, who are, really quite committed to dying by suicide and choose methods that will achieve that. Great talk, though. Really enjoyed it. Thank you.
Yeah, thank you. And I agree. I think, looking way back to when I was sort of getting my voluntary experience and thinking about kind of trying to get on the training in clinical psychology and working with people making a transition from forensic services who had experienced psychosis, the most violent methods were certainly in that population. And I think you're right, the severity of the illness is probably one of the biggest factors there.
Kevin McConville has written, thank you for the really interesting talk. For the two patients on screen who you've circled back to here, patient one, if referred to community health services, will be, he's in quotes, rejected on the basis of needs to self-refer to substance misuse services and occupational health to have a direct route to mental health services anyway. And patient two might be rejected on the basis of, have you tried online CBT services first? So the GP isn't likely to refer either to begin with. We'd probably try and self-manage. For context, Kevin is a GP for part of the time and is the head of the MBCHB program undergraduate medicine here.
Yep. So one of the things I was thinking about I find myself thinking about a lot is anybody who discloses any kind of substance misuse is going to be probably rejected based on the criteria of the various teams I've worked in for having an active substance misuse problem, even though it can be a real warning sign of psychiatric illness and or suicidality. And patient 2 being referred on to online CBT, yeah, she probably would be for self-management or for guided self-help. And I could, talk for a long time about whether I think either of those things are right or not. I don't think either of them are right. That's the short answer.
Very
really
constrained services,
yeah.
clearly, and very challenging, particularly with the rationing of the relevant expertise available. Fhiona, so you have your hand back up.
I do. I'm really glad I came along today. There's a huge amount of work going on around the interface between substance use services and mental health services for exactly that reason. These clients are really high risk and for a long time haven't had the kind of treatment that they need. So I think that's been recognised at national level now.
Yeah.
So are there any more questions or comments that anyone has anywhere? I can't see anybody. So excuse me for a second whilst I just try and find something. But one of the innovations that the Department of Medical Education has started is that they are trying to capture attendance at the grand rounds and various other things. And what we've now got is a QR code, which I'm desperately trying to find so I can share it with you, which enables you to be able to go straight to a form. You can fill it in, you can say that you've been to grand rounds, and that allows you to then, you get a certificate back that says you've been to grand rounds, and you can put that in your appraisal, or if you're a trainee, you can put it in your portfolio, and if you're just somebody who's watching this on YouTube, then, well, you can have a certificate for it. I'm going to share the QR code in a second once I manage to do it, and then you can scan this and you get a certificate. I need to bump you off the screen, I'm afraid. And here it is, he says. So if you want to scan that, it should, fingers crossed, take you to a form that allows you to get a certificate. Now, do give me some feedback to make sure it works. If it doesn't work, then I can get it changed. Next week, Professor Rory McCrimmon, the Dean of the Medical School, is going to come to Grand Rounds to talk about the review of the year. So if you want to hear what the university has been up to, the advances, the successes, the struggles, the challenges, and the innovations, then dial in next week. Same place, same time, same link. Thanks, Fhiona, for a really fascinating talk. Really enjoyed that. I thought it was really, really important to hear, and really, really very, very interesting, and stimulated a lot of conversation and questions. So thanks again. And I shall see you all next week.